Okay, so hello and welcome to day 4 of Clinical Audit Awareness Week 25. So we've been running the lunch and learns with all through week with today's topic on influencing change and how we can effectively utilise clinical audit to drive evidence-based improvements and support people to live well for longer. So my name's Vicky Patel, Chair of NQICAN and Clinical Effectiveness Manager at the Rotherham NHS Foundation Trust and your Chair for today's lunch and learn. You'll note that the event is being recorded, which we will make available to you all to access post-event today alongside the slide packs. It'd be lovely to see your cameras on, but obviously if you don't want to be recorded, feel free to turn your camera off. Your mics have been muted and they will be activated at the point that you raise questions, and the Q&A function is live, so please do also utilise this to post a question or add a comment relevant to today's lunch and learn. So if we can move on then, we'll just have a look at the programme for the week, please. Brilliant. So you'll see that we've already run 3 daily lunch and learns, and obviously today is influencing change, being run between 12:30 and 1:45 p.m. daily. Links are on the NQICAN Future NHS Workspace and also over on the HQIP web pages. But again, as mentioned, today's topic is on influencing change, and it does remain important and supports all of the other daily topics that we've been having a focus on this week, and obviously they all support the domains of quality. So if we move on, we'll just have a look at today's agenda for you. Lovely. So we'll just begin with a quick introduction and a recap and touch on last year's takeaways to set where your thoughts are at as we focus on today's topic. We will hear from our key speaker on key information and points that we need to be aware of and consider when influencing change. We will provide the opportunity to ask questions, and then the Clinical Audit Hero Award winner for influencing change will be announced. They'll present, and again, the opportunity for questions at that point. And then before we close at 1:45, we'll ask you to join in with an interactive evaluation on screen. And then finally, as always, we're going to task you with taking away a challenge today to take back to your own organisation. So if we move on, we'll just take a little moment here just to reflect on the key takeaways from last year then. So this is what our colleagues said that joined us on the Influencing Change event last year. I'll let you read the comments that are on the screen, but just whilst you do so, I'm just going to touch on the challenges that we set you last year and that we do ask you to reflect on and consider as we're going through today's event as well. So we directed you to the Making Data Count resources and training that was on the Future NHS Workspace, and we'll continue to direct you there. There's a fabulous suite of resources and trainings, so we'll provide the links for you today and post publication of the recording and slide pack. We asked you to get in contact with your informatics teams and start to build a stronger collaboration on how we can effectively utilise that data to inform decisions. And we asked you to consider carefully how you were presenting and translating that data to your decision makers that then led into those smart improvement plans and how you might then evidence the impact of change. All still relevant takeaways for today's session as well. So if we just move on for a minute then, I'm going to just task you with that focus on bold and ambitious that we gave you last year, but then also this year starting to think, right, we want to task you with focusing on that. How do we add value and how do we add impact as well? So each day this week, we've just been raising some of the key points that Lord Darcy focused on within his review of the NHS last year. So I've just pulled out a few more key points for today before we hand over to Claire from HQIP and then Sam Riley, our key speaker. So that review provided that comprehensive diagnosis of the system's current challenges. It outlined a vision for reform. And as we've gone through and reviewed that paper, clinical audit is definitely coming out to have that pivotal role really in supporting that implementation of the vision, but also implementing change in quite a few areas. So just starting to look at that evidence-based improvement then. So that review emphasised the need for that data-driven decision making to address the systemic issues around things such as that long waiting times, declining health outcomes, and that underfunding. And clinical audits provide that robust real-world data on the quality of care. They start to help us to identify gaps between current practice and best practice, and that aligns directly with really what the review is asking us to do. Then when you start to look at quality and safety as well, it highlights the fact that but it feels there's been that deterioration in that care quality in some areas. And we know that clinical audit systematically assesses care against established evidence-based standards, making it an essential tool really for identifying safety concerns and helping us to drive that continuous quality improvement, especially in high impact areas such as at the front door in A&E, surgery and chronic disease management. And then empowering frontline staff, one of the review's findings was around lack of staff engagement and that voice in shaping services. And we know clinical audit is a powerful tool for engaging clinicians and involving them in evaluating their care and improving their own practice. And then that focus on supporting integrated care, it asked us for better integration across services. And we know that clinical audits can be designed to span care pathways, so it can go from primary to secondary care, highlighting where coordination breaks down and where improvements can be made. And then finally, around that efficient use of resources, and we know that there's a shortfall in monies that's available, and audit data can help to inform policymakers and decision makers where resources are most needed. So we need to use data and wider intelligence that's accurate, timely, and transparent to influence change. We know clinical audit is a powerful evidence-based QI process that supports health and care to use data to guide change. It involves staff in making quality improvements, and we know that we can facilitate the partnership working across our organisational boundaries for our patient pathways, and importantly, ensuring we do listen and we hear the voice of those that use our services. So I'm really pleased now at that point to hand over to Claire Fountain, Associate Director at HQIP for Quality Improvement, who's going to spend a few minutes touching on Clinical Audit Awareness Week and change from HQIP's perspective. So I'll hand over to you, Claire.
Brilliant. Thanks very much, Vicky. So absolutely support everything you've just said in terms of the strengths of clinical audit as a methodology. We're all here because we believe that clinical audit remains one of the NHS's most effective tools for improving patient care and a great asset to everyone's QI toolkits. And the entries this year for the Influencing Change category also really demonstrate why it's one of the most relevant methods for the future. And so I'm just going to talk a little bit about some of the entries, and I won't give away the winner, but I'm just going to talk about them and what I was particularly impressed around this year. So I had the pleasure of judging this year's submissions with Vicky and others. And it was great to see clinical audit being used in impactful and indeed remarkably different ways to influence change, learn from variation and lead improvement. So one of those ways was around supporting evidence-informed care. And in the entries, we had the STOMP clinical audit in North East London, and that tackled inappropriate prescribing of antipsychotics for children with learning disabilities. And that not only made change locally, but also informed national guidance and as well as that kind of local widespread practice change. In Coventry and Warwickshire Mental Health Partnership Trust, they improved alignment to national best practices, and that included cutting tranquilisation by a whopping 50%. And in Bolton, a palliative care clinical audit aligned emergency care with national standards, reducing avoidable admissions, saving over 1,000 bed days, and supporting same-day discharge through better planning. Clinical audit also helps translate national data into local improvement. It doesn't need to just stay as national here and local there. They can be very much complementary when used together. And at UCLH, combining NASAL's findings with local clinical audit led to daily specialist reviews and a culture shift in end-of-life care, a strong example of a true learning health system. Clinical audit also puts the patient voice and experience at the centre. And, you know, going back to Darcy, he talked about how the patient voice isn't loud enough. But the MSI Reproductive Choices UK IUD clinical audit, that's a mouthful, ensured that local anaesthetic was offered in all cases and halved reports of severe pain. And they directly addressed concerns raised by women about the service that they were receiving. Clinical audit is also an enabler for the future innovation, and particularly digital transformation. An example of another entry, East Suffolk, the clinical audit evaluated a digital rehab programme for long COVID patients, introducing self-management, reducing fatigue, and delivering value for money by actually bringing £8.55 return for every pound that was invested. So it saves money by improving care, which is, as we know, the best way to improve care. And the hydrocephalus clinical audit, also on the technology side, showed that implantable sensors reduced admissions, radiology exposure, and costs, and in a way that supported national adoption. Next slide, please. If you can skip 2 slides, you'll see I did put a little blurb on there, but I've talked it all through. So next one, that's it. Brilliant. Thank you. And across every example, clinical audit is helping to deliver the changes the NHS needs right now. So the examples of the entries that we saw were supporting personalised care, they were supporting digital innovation, reducing variation and greater value. And as Vicky said, you know, clinical audit is a really rigorous and trusted methodology, and we need to be the advocates for that and really show what clinical audit can do as a tool to help as part of people's QI toolkits. It's an approach that's structured based on evidence and clear standards, and it's also a highly effective driver of reflective clinical practice. So what I was saying around it being at every level, from national to local pathway change, but also just at the individual clinician level. It's a collaborative methodology led by teams who really understand the services and how they work. It centres on continuous and not just episodic improvement. And that is a particular thing at the moment that I think is a lot of discussion in QI circles, that actually it can't just be a one-off change and expect that you've done your PDSA cycles, you've achieved some change, and then no ongoing monitoring. Clinical audit is very much looking in there for the long term, looking at sustained improvement. And of course, it's the methodology, as I said, that's adaptable and useful in every setting and at every scale. And finally, of course, it delivers great value. And we know, you know, value is what we need to achieve right now. So you're all part of delivering that. And just some of the entries were just really inspiring this year. So thank you for your entries, your leadership, and your commitment to making care better through clinical audit. Next slide, please. Oh, okay. I thought there was a slide talking about the events, but there are more events happening this week, which I think Vicky's already covered. So now I'm delighted to hand over to Sam. And later on, you'll hear from the Clinical Audit Heroes themselves. Thank you.
Thanks, Claire. Fantastic. Lovely to see so many people. Now I'm going to take control, and we tested this earlier and it worked. So let's have fingers crossed that it's going to work now. So lovely to see everybody. I have presented at this event for a few years now, actually. So some of you might have met me before. So I'm Director of Making Data Count at NHS England. Well, I am, at least for now. Who knows what the future might bring. But I'm going to ask you to use some emojis, actually, maybe as we go through. So do you want to give me a thumbs up reaction if you already know about Making Data Count? And maybe you could do a surprised face if you don't know. But that's good, Vicky, because we've got lots of thumbs up. We've got some surprise faces. There's lots of training that you can join. Vicky's going to circulate dates. But I'm going to take you through a bit of a story today and build on some of the stuff that we've talked about before. And there was a little delay earlier, Vicky, wasn't there, when I tried to move a slide, but it did eventually wake itself up. I can see my little face on the slides.
Yeah.
So come on, computer, you can do it.
Keep nudging.
And then we'll skip 5 slides. That's what's going to happen, isn't it? Come on, computer, because this really isn't going to work very well if I need to say next slide. But, oh, look, okay. Look, we're all over the place now. We're moving. Okay, so we've already heard about Lord Darzi a couple of times. I would recommend you to read the summary report because I think it's a really good and useful document. But the summary of that report was that the NHS is in serious trouble. That's not where we want to be. And Vicky's run through this already. So there were some key themes that came out throughout that. There's some significant change that's going to need to be happening over future years if we're going to do all of these things on the slide. And you know what? we've got to do that with less money. So that's a real challenge, isn't it? Really, really difficult. Now, the 10-year plan is going to be forthcoming. You can see from here that it was promised in the spring. Clearly, spring has come and gone. Hopefully, it will be very soon. So coming soon is the 10-year plan. We know, we can see on this slide that it talks here about long-term pressures around an ageing population. I have clicked twice and nothing's moved. This is frustrating, isn't it? We're going to keep the faith. Oh, look, here we go. So here we go, ageing population. Now, already we have got national priorities that have been published. One of the priorities identified within here is a shift towards prevention. And I don't know if any of you have come across the NPAF document, the NHS Performance Assessment Framework document. This was out in draft. I think the consultation on this is now closed, but we can see here that the management of long-term conditions is absolutely critical. And I've circled the diabetes metric here because we're going to have a little story in a moment. That's exciting, about a patient with diabetes. Now, you all know who this is, Albert Einstein. I wonder if you know this very famous quote from Albert Einstein about insanity. So insanity, doing the same thing over and over again and expecting different results. We never do that, do we? I think we might sometimes. Henry Ford, do you remember Henry Ford? He was quite famous too. He said something similar. If you always do what you've always done, you'll always get what you've always got. So if we're going to achieve what was outlined in terms of Lord Darcy's report, we're going to have to do something fundamentally different, aren't we? We can't continue working in the way that we have done. So I'm going to tell you a little story. It might be a fairy tale. Let's see. You can think about it at the end. But I'm hoping to weave together some of the themes that we've covered before, along with some new themes, building on the stuff that Vicky said at the start, around how you can make a really valuable contribution to patients living healthier, happier, longer lives, because we're all in the game, aren't we, of trying to do that. So let's move into our story. Look, I'm even turning pages now. Now, the first character in our story is Amit. Here he is. He's very happy to meet you all, very excited to see so many people on this session. He's not looking brilliantly happy though, is he? So Amit does have diabetes. So this is the diabetes link. That's why I circled that earlier. Now, Amit over the past year has had 43 health-related appointments. That's a lot, isn't it? And that's with lots of different types of clinicians for different things. He is quite overweight. He's quite lethargic. It's difficult for him to get out and do much. Therefore, he is quite depressed. He doesn't look very happy, does he? He looks quite sad. He is socially isolated. And unfortunately, poor Amit has had 3 hospital admissions in the last year. And they were quite lengthy admissions. The first one was when he had a really, really difficult episode when his blood sugar was very uncontrolled. And he was in for quite a while in his local hospital, which is St Elsewhere. He's also had a real problem with his feet. So he's had ulcers on his feet. My brother-in-law, he spent many months in hospital with an ulcerated foot. So that's not good at all. And then he had a 3rd admission and ended up on a drip for quite a long time because he had a kidney problem. So that's Amit's experience. That's why he's looking sad. So his local trust is St Elsewhere. If some of you have joined our training sessions, you'll know we sometimes go and visit St Elsewhere. Now, thinking about St Elsewhere, there's a problem at St Elsewhere. And here we've got our second character, the Chief Exec of St Elsewhere NHS Trust, Hugh G. Overhead. That's a funny name for a Chief Exec, isn't it? But look, he's got his yellow "My name is" badge. So that's very good. Now, why is he looking sad? Well, the good thing about this trust and elsewhere is they have done making data count training. So some of you will understand what this graph is telling us. This is a making data count chart For those of you that don't know what these charts are all about, join our training. But for now, I'm just going to say if we've got orange dots at the end of a chart, it's a bad thing. And if we've got blue dots, it's a good thing. And look at what we've got here. We've got 6 orange dots, and we're looking at average length of stay, non-elective length of stay for St Elsewhere. So this is starting to explain why he's looking quite unhappy. For those of you that have done our training, you'll understand this little table underneath. If you don't understand it, you can join our training another day. But what do we learn here? Because this chief exec knows about his data and he understands it. We can see here that it's medicine that's driving that increase in length of stay. So what on earth is going on? So moving to Ward 7 in St Elsewhere, here we've got Kirsty, who's the ward manager. She's looking quite stressed, isn't she? So it's been busier than usual. Staff are really stressed. She doesn't really know what's happened. She doesn't know what to do. So there's a lot of tension, isn't there, in St Elsewhere at different levels. But the good news is we've got a really cheery, helpful clinical audit lead called Jenny. Look, she's the only one with a smiling face so far. And she's really, really keen. She knows Kirsty. She's known her for years. She really wants to try and help out and do what she can. So what's the problem on Ward 7? Well, Jenny goes back and looks at her records. There's a problem here. She really wants to help, but you know what? The last audit on Ward 7 was 12 months ago. We've talked before, haven't we, in sessions like this, about the fact that if you're doing an audit on an annual basis, that isn't necessarily the best method by which to drive improvement. But for Ward 7, the last audit was a year ago, so it's not going to help. She doesn't really know what to do, but, and some of you might feel the same here, she's heard that there's a team in the basement that deal with data. Some of you might work in trusts where you've got a team that is in a porter cabin or in a basement that deals with data. I reckon so anyway. She's going to get in touch with them. So she gets in touch, she walks across down to the basement, and here she finds Nina, who's an analyst within the business intelligence team, and she asks Nina, is there anything that you can help with? And absolutely, she can. So here's the first important link. Vicky's referenced it already. It's really, really useful if you can link up with your business intelligence teams if you're not already. So Nina goes away. She's had a bit of a chat about what the problem is, and she's thought about some analysis that she can undertake. So let's have a look at Nina's analysis. So here we've got average length of stay for inpatients with diabetes on Ward 7. That's the first graph. And the graph next to it is for non-diabetic patients. So what do we learn from this? Well, there's been a significant increase in length of stay for diabetic patients. That's very clearly seen. No change in length of stay for non-diabetic patients. There is a mix of patients that are being admitted to Ward 7. Now she's done some work to look at themes. So some of you might recognise a chart like this. You can give me a thumbs up if you know what a Pareto chart is and if you're familiar with them. This is a Pareto chart. It's really, really useful to help us theme things and identify where our biggest challenges are. So here we're looking at the top delays for patients that are in Ward 7, and here we can see the first bar in the orange is social care delays, so they're contributing the greatest amount. The second bar there is looking at poor glycemic control. So if we're going to try and sort out the problem of patients being delayed, we're going to want to focus on those 2 bars because they are the areas that are affecting the vast majority of patients. So we do training on Pareto charts, and we have a tool. Another little advert there. Have to do my adverts, Vicky, sorry. So we saw there that poor glycemic control was the second bar, so it's creating a significant problem in terms of delays. Let's have a look at what's happened over time. And what we can see here is, look, those delays, poor glycemic control delays, have increased significantly over time. So we're building up a bit of a picture here, aren't we, of not great stuff going on around diabetes. And we've got some different data here, which relates to the number of medication error incidents for all of the wards across and elsewhere. And look, that black bar is Ward 7. Now, our analyst Nina, she went along and she found somebody from the finance team, and they did a bit of analysis to look at the cost of these delays and look at how much medication error incidents related to diabetes have cost the organisation. So make friends with your finance colleagues, not just your data people, because they can bring a different kind of part of the jigsaw to you. Now, final thing that we've got here is referrals to the diabetes team. So how long are the referrals taking? Look, we've got orange dots again on the chart. So that's not good, is it? Not good at all. So not a happy picture. But I have to say, you know, Nina's done a fantastic job. So we are, of course, going to thank Nina for this analysis, and we're going to buy biscuits. Always works well for analysts, might work for clinical audit people too. But we've also got a basket of fruit, because obviously this is about diabetes. We don't want to increase people with diabetes. So thank you, Nina. That's been wonderful. Brilliant. We've got a lot of data now. So we're not just going to do the analysis, are we, and have a look at it. We need to decide what we're going to do about it. There has been an urgent meeting called. They've even got the boardroom for the meeting. So we've got the ward manager, Kirsty. We've got Jenny, our audit lead. We've got Nina, the analyst, and we've got Paul, who's the diabetic specialist nurse. Now, this is quite a forward-thinking trust. And the great news is that Nina's come along to the meeting and they've got a projector set up and everything, and she's decided that she's going to present some additional data live in the meeting. That's always a good thing to do, and we can talk about that another day in detail, but it's really useful if you can look at live data in a meeting, which is what they're doing. Now, this particular graph that you can't see because it's very small, isn't it, but we're going to have a look at it in a bit more detail, is of real interest to our diabetic nurse, Paul. So let's have a look at the graph. Before we do, he's really interested in the graph that we're about to look at because he's felt really busy. The whole team's been really tired, and the graph is going to reveal why. So what can we see here? This is referrals to the diabetes service. Wow, they've gone through the roof, haven't they? Significant increase over a sustained period of time. No wonder they felt busy and they felt tired. Now, Paul doesn't understand the reason for this. He knows he's been busy, but he doesn't know what's been going on. He's taken away an action, and his action is to go and do some further investigation to find out what on earth has happened. So Paul is a bit old school. He thought about sending an email to his colleague, but he's decided that no, it's good to talk. It's quite unusual now, isn't it, to actually pick up the phone to somebody rather than send an email. But that's what Paul does. So he's picking up the phone. He's got a colleague who he's met a couple of times before, a community nurse called Gwen. They have a bit of a chat about what's going on. Gwen isn't that sure either, so they do need to do some more investigations to find out what's the cause of that increase. But meanwhile, going back to our lovely clinical audit lead, Jenny, she's been mulling over the stuff that she's seen and she really wants to be able to make a difference. So she's had a bit of a light bulb moment and she's got an idea. She's got an idea about how clinical audit could really help this situation. So what's her idea? Wow, you're on tenterhooks now, aren't you? You're on the edge of your seats. What's Jenny's big idea? Well, she knows she's done some work on diabetes before and she's done some investigations, and she knows that lots of organisations are involved in providing care of different types to patients with diabetes. There are lots of different organisations that are involved in this across the pathway. So we've got a community trust, we've got the ICB, we've got primary care, we've got social care. So she's been very proactive. And look, she's made connections. She knew one of these clinical audit people. She knew the lady in the community trust, but she didn't know all of these other people. So she's gone out and she's been proactive and she's got in touch and made connections with all of the clinical audit people. And they've done the same in terms of finding their business intelligence colleagues and their finance people. And they've got together, they've had a big meeting, they've set aside the time to get together, have a discussion and decide what they might be able to do. Now, they put together a bit of a case because the evidence was quite strong about the fact that diabetes had some real issues. They They thought that this should be a priority for every part of the system if there was going to be significant progress made across the diabetes pathway. So each of those clinical audit individuals has gone back to their organisation, they've taken evidence, they've taken the data, and they've got agreement in each of their organisations at a senior level that this is going to be a priority. So there's going to be a significant amount of time dedicated to looking at diabetes and agreeing an audit plan across the whole of the system. There's ownership from the stakeholders because people have been involved. And look, we've got agreed audit questions. There's going to be monthly audits undertaken, none of this annual stuff, because then we'd take forever, wouldn't we, to be able to see if any difference has been made. People are clear about what they're doing. They've established forums with the right people in them to review the data. And alongside all of this work, another team that I'm hoping that you're already connected with in your organisation are your improvement teams, because we're going to need their support, aren't we, once we've got further evidence about what needs to happen. So that's a good job done there. And look, they've earned some really good brownie points. Everybody's really pleased. But now, of course, we do actually need to do the work, don't we? There's no point in just coming up with a lovely plan. We actually need to implement the plan. So they've looked at the pathway. There's loads of work, isn't there? There's loads of audit-related information around diabetes. They've prioritised which points they really want to focus on, and they've developed quite detailed plans that are going to be implemented in different parts of the system. And Nina, of course, and her business intelligence colleagues are going to be involved in this going along, because let's not forget, and you'll know this already, I'm sure, we need to take a baseline before we do anything, don't we? Because if we don't take a baseline, we're not going to know if the changes that we're implementing are working. So Nina's going to take a baseline and she's going to ensure that everything's monitored going forward. So she's done loads of analysis in terms of baseline information. We're only going to look at a few examples of it. So what have we got here? The number of newly diagnosed diabetics. So this is in somewhere ICB, that very well-known ICB. So what can we see? A significant increase in new diagnoses. So that's interesting, isn't it? There's a question to be asked there. Do we really understand what's happened with our population? This is suggestive that something has changed with our population. What's next? Percentage of diabetic patients with controlled HbA1c. So it looks like it's becoming harder to manage those patients. So if they're becoming harder to manage, will patients be sicker when they get to hospital? Quite potentially. Now here we can see a significant decline in diabetic patients with recorded annual foot checks. That's surely going to be something of real concern, isn't it? What's going to be the long-term impact of that? I know from personal experience it can be really, really significant. Can be life-changing for people. And here we're looking at the percentage of diabetics referred by the GP to secondary care. So that's interesting. Nothing's changing there. The grey dots mean nothing is changing. So does that reflect the needs of the patients, or is there unmet needs? So that's just a little handful of examples from Nina's analysis. But we've got a load of questions now, haven't we? Now we're going to do some time travel. Time travel into the future. Loads of work's been done. All of those clinical audit teams, business intelligence teams, service improvement teams have done loads of work. Look, that's the time travel transition. So now we've moved forward in time. We're looking at the same 4 graphs in a dashboard. And look, we've got 3 charts with beautiful blue dots. And if you've done making data count training, you know that's always going to make us happy, because that is showing our significant improvement. Fantastic. That's, of course, to be celebrated. Wonderful improvement work. So look, our clinical audit team are super happy now. Really great work. Now they do now have a strong network of clinical auditors, and they didn't have that before. So they do get together on a regular basis. And of course, now they've moved on to other things in addition. But you know what they've done? This is something some of you might want to consider. And I know we've got awards being announced very shortly, but surely there's an HSJ award. Well, there was this year, because they put in an application and they won an HSJ award. because they'd got such strong evidence of improvement in their data and they had such a robust whole system plan. So that was absolutely brilliant. And Vicky will know, well, that's a real cause for celebration. Even blue dots for me is a cause for celebration. But they went to the HSJ Awards dinner and they had to celebrate, didn't they? So here they are, boogieing the night away, having a fantastic time. Look, they scrub up quite well, don't they? They had a fantastic night, which was amazing. But of course, the reason for all of this work has been to improve the lives of patients. So at the same time, look, now we've got much happier patients. They're much more active. We've got well-controlled blood sugar level. They're doing stuff together. They're looking much happier. And that's what we're in the game for, isn't it? To make our patients' lives much happier, much longer. We want lives in better health rather than just extending the years. So, what were the key ingredients? And I suppose things that I want you to take away. So, our clinical audit lead, Jenny, she was really proactive, wasn't she? She went away, she thought about what she could do, she offered to help. And I'm sure that all of the people on the call are like Jenny's. But sometimes it's a bit difficult, isn't it? We're busy. It means we need to look outside the box. Jenny couldn't have possibly solved that whole problem just by looking in some elsewhere. She needed to look much more broadly. So look outside your organisation, look outside the box. Now she learned that joining forces was such a powerful thing to do. So again, think about what networks you've got locally. Can you join forces with others? And that won't just be clinical audit people, it will be people in other types of teams. And be brave, because I think that Jenny was really brave in that story. So she was proactive, but also brave. It can be scary, can't it, reaching out to people? Because what if they're not interested? That might be a bit tricky, but I think it's definitely worth going for. And you probably need to be persistent, because I can tell you that not everybody was delighted to be involved in this new significant piece of work with Jenny. She did have to use her persuasive skills and be persistent, but it all paid off, didn't it? And we've always got to plan and make sure that we celebrate success, because I think that sometimes we do lots of amazing work and then we kind of move on to something else. It's critical, isn't it, that we celebrate success, we say well done, we get our disco clothes on and we go and celebrate that, because that's what's going to keep us all going and motivate us to do more. So there we go, the different parts of the jigsaw. So if we get all of those parts right, we're going to end up with people that are living longer, happier lives, doing what they want to do. So here's a little selection of people. I do like gardening myself, so that might be me doing that in my old age, which is increasingly upon me. And I probably wouldn't be doing this next one. Not a fan of filleting fish, that wouldn't be for me. But hey, different things, different people. I'd like to watch that, but I'd be no good at doing that. But of course, clinical audit can contribute to all different types of clinical problems and all different types of patients that need help from the NHS. So that's leaving 7 minutes for questions, Vicky. Not bad timing. So that's all, folks. Thanks for listening. I'm going to hand back to Vicky, I think, in terms of questions. And these are making data count colours in the flashing dots here. If you don't know what they mean, you need to attend the training. So Vicky, back to you.
Lovely, thank you. So I'm going to go to raised hands to begin with. So if you've got questions, raise your hands, and we'll also monitor the Q&A as well for questions. We did have some hands up and now they've gone down. No, Sally. Oh, people keep putting their hands up and putting them down. So it's, have we got any raised hands?
Well, that's because people might have wanted to clap and they pushed the hand up instead.
Yeah, accidentally. Okay, so I'm not seeing any hands at the moment, but I'll just get Louise to keep an eye out as well, and I'm just going to head back to the Q&A. We've got some nice comments in the Q&A as well. So how can we attend the training you keep mentioning? We're going to pop the links in the Q&A for you. We're going to publish them as well when we publish the recordings and the slide packs, but it's the Future NHS Workspace that hosts all the Making Data Count training and resources, which I have to say are absolutely fantastic. So that was one question.
To make people aware, the 10 modules that we've got are all CPD accredited, so people have got the opportunity to earn up to 10 CPD points, and you do get certificates. So there's an incentive. And Vicky will have, if we exist into the autumn, which of course is very unclear, we will have 2 new steps, I think, coming soon.
Brilliant. Oh,
Yeah.
that's amazing. That's really, really good. In which case, if you haven't yet undertaken those steps trainings, go in and get registered on the workspace and start from step 1 up. Lovely. So I think Bren, you were asking to be unmuted to ask a question. And then I can also see another hand.
Nice comment from Diane. Thank you. Storytelling is quite powerful, I think. Obviously, that was a made-up story, but hopefully it was plausible.
Yeah, I'm not hearing Bren managing to unmute, so I think we've got another hand up, and is that Susan? Susan, are you unmuted?
Yes, and it's not a question, it's a comment. Just to say, I'm halfway through the Making Data Count training at the moment, and it's blown me away. It's absolutely fantastic. They start the first module, they start with, this is going to change your life, and you think, yeah, fine. Humorous comment, you know. No, it is absolutely one of the best things I've ever done working in health and social care, and I can't recommend it enough to my colleagues here at North Cumbria and people elsewhere. Do it. It's marvellous.
Oh, thank you so much. You brought a tear to my eye there. I'll pay you afterwards. But well, we do try to make a difference. We trained 48,000 people now, so the more the merrier, yeah. But thank you very much.
Brilliant. It's definitely having an impact, isn't it, locally, but for us all in our organisation. So yeah, Rosie's just asking about access, so we're going to get the link popped in. I think Bren's left and he's coming back. Yeah, lots of questions about attending the training. So I'm not seeing anything else in there at the moment.
Shout out to Adam in my team who created all of the graphs, so and the characters. So shout out to Adam. Thank you very much. Couldn't have done it without him.
That's brilliant. Yeah, thank him on our behalf as well, Sam, because it's brilliant. And obviously we'll share the recording, so obviously we'd encourage you to share it widely with your colleagues as well that perhaps haven't been able to attend today. So I'm thinking then, Sam, if that's the case, we're going to move on to the next slide. Oh no, Claire's got a hand out.
Hi, thanks, Vicky. It's kind of a question for anybody else following on from Sam's presentation. So, looking at pathways and how we've traditionally done clinical audit, it's been very much along pathways. And talking with one of the ICBs yesterday, it was really clear how the volume of complex patients is going up and up and up, and how we need to adapt the way that we use clinical audit to look at by a person level, a community and a population health level. So that really chimed with me, Sam, in terms of what you were saying around this individual is going to lots of different services. So if anybody has done any work with their ICB looking at how can clinical audit data inform population health analysis to say, okay, we've got this issue, but actually which cohort of patients is it that we need to work to? What's it telling us about the frail elderly, for example? If anybody's doing any of that kind of work, I'd be really interested in having an offline conversation. Please contact me, claire.fountain@HQIP. Thank you very much.
Thanks, Claire. And obviously most organisations now have got their public health consultants that are helping with the health inequities, but also that access to that population health data, which you can also access through those collaborative partnerships with your ICB. So thank you. Okay, I think we will move on to the next slide then, please. Back to you, Sam.
Drum roll. So I always like doing this bit, Vicky. I've got through my slides and then I do the really nice bits. So I've got the fantastic job of announcing the winners. So I'm going to announce the runner-up first. And great to hear from Claire that there were lots of great entries this year. So the runner-up, drum roll, very good slide, is Suffolk and North Essex Long COVID team in partnership with CAAW25. So the project was evaluating the impact of a novel digital service alongside routine clinical care for post-COVID syndrome. And in terms of the judges' comments, the project had a clear description of the problem with clinical and PROM metrics, including useful use of QALYs and other statistics. We liked how it presents some metrics to improve on in future years. They commended its scalability, releasing pressure on services and measurement. So well done, everybody. Congratulations to the runner-up, but massive congratulations to the winner. So the winner, drum roll again, bigger drum roll, Dr. Emily Collis, Transforming End-of-Life Care Team. So this was University College London Hospitals, Transforming End-of-Life Care Quality Improvement Project. So the judges' comments, this project had a well-described problem area with defined intervention and good use of electronic clinical records. It was a nice example of using local audit and national audit data to inform decisions. There was great sustainability by building into EPIC, and it was really nice to see crossing ICU, community and end of care services. So that's a nice link with what I talked about, isn't it, in terms of across the pathway. So many congratulations. And now I think I'm going to hand over to Emily and we're going to hear more about what they did.
Thank you so much. I'm super delighted to win, and even more so having heard about the calibre of the competing people and teams. So thank you so much for this award. It means a lot to our team. We've been working a long time trying to improve end-of-life care in the acute hospital setting for our patients at UCLH, including, as you say, into the community. Next slide, please. So it was actually our local governors who, of their own accord, got together and wrote a report that triggered the focus on this piece of work. And they did qualitative study talking to relatives of recently bereaved patients and looking at what the gaps were in end-of-life care, and they came up with really quite difficult reading, I have to say, for us in terms of what we needed to improve upon. And as a result, we did a bit of a needs analysis and an options appraisal and looked at how we could improve care. Their suggestion was actually that we set up a hospice unit within the trust, but as we're all aware, the financial context in which we're working, we need to think about the most cost-effective solutions. And so we looked at priorities for education, for bereavement support, and also for looking at what was a realistic clinical service development for patients at end of life across the trust. Next slide, please. So rather than give you a whole ton of data, I've only got 10 or so minutes, so I just wanted to give you a bit of a flavour of the narrative of how we used audit data to improve the service. And the audit data was really the key pillar. It was also how we presented that data, how we communicated it, how we exerted a sphere of influence within the trust. So there was a lot about building relationships in order to get that data into the right places, to get it heard and to get change to happen. So the data we were using was not just the national data. So from the NACL, I don't know if you're all aware of the National Audit of Care at End of Life. It used to be that was an annual data submission, and then more recently, thankfully, they've increased the frequency. It's got several different elements to the audit, including a case note review, and that was our key national data that we were able to pull together. And then in terms of local data, we were doing local regular audits of care for patients in the last days of life, and also for decision making a little bit upstream of that. So thinking about the resuscitation decision, the DNA CPR decision, and the treatment escalation plan, and linking those two things, because we know that if patients have a do not resuscitate order without a treatment escalation plan, they're at risk of harm. So that was one of the key bits of data we were tracking and reporting on. And then in parallel, the trust rolled out Epic. So we went from paper records to an electronic record. And it was actually with Epic that we were able to be much more accurate in our dashboard across the trust in knowing which patients were dying, knowing the information about the resuscitation status, the treatment escalation planning, and then also developing templates through a QI process to kind of improve the care. Next slide, please. So in terms of the educational theme, we're a small team at that stage. We were just myself 1 day a week, a band 7, a band 8, and a project manager. So a very small team trying to influence change across the whole trust. So education was one of our key strategies. We developed and rolled out courses. So talking about the patient safety awards, we were shortlisted for one with our Talking DNA CPR course that was an intense 1 day course for quite senior band 7 CNSs and above, and medical trainees, band ST4 and above, and consultants, really to look at having those conversations around DNA CPR in a timely way and to think about the ethical and medical legal implications of that. We've actually just this year relaunched that course to be a TEP Talks course, because I think actually we've moved on from DNA CPR being the key discussion to really most people are aware of the need to have the DNA CPR, but they're not having that treatment escalation plan course conversation, which should actually predate that. So that's being relaunched as we speak. Next week, our first full run of that. So hopefully that we can take some, we can evaluate and see where we go, because all these courses that we run, we have evaluated and then work to try and continually improve. And now for the past few years, we've had this compassionate conversation courses for nurses and HCAs, again, a full day course. So they get to really think about their barriers to discussing with patients their concerns around approaching end of life. So just a few numbers there, but in general, we aim to teach to over 1,000 patient staff a year in terms of episodes of teaching, and we've maintained that over the last 2 years. And then also using our data and our recommendations to inform policy and also patient information leaflets. Next slide, please. Then bereavement support. This was obviously incredibly important in COVID when relatives were unable to come into the tower here and see their loved ones. So this was a key focus. So we updated our bereavement policy, made sure that we're doing bereavement assessments on the pertinent loved ones of the patients that die at the trust, and updating the policy. And then also making sure that we keep track of the data of how many of the patients that we're looking after are receiving the calls that they need, how many are receiving the information, etc. Next slide, please. So in terms of the clinical service development, as I said, we did an options appraisal, and it would have been financially not viable to open a hospice unit within the trust. And we also were very aware that from experience, patients die sometimes unpredictably across all specialties, across all clinical areas, obviously some areas more than others, but it was important to us that actually we didn't just have a sole focus in one small geographical area of dying and then other patients in other areas would get left out. We wanted to be able to target the education, the quality improvement, the improvement in patient care to patients wherever they were in the trust, and not have them move and break what had been continuity of care, the building up of relationships with their treating teams over time. So we wanted to take the service to them. So we used the data from NACL. We also used the data from our local audits and submitted a business case initially for a charitable funding pilot for 2 years to deliver once a day review, and on average these reviews were 45 minutes to an hour long, and the review is not just to support the patient themselves but also the family members and then also the staff who are on the ward looking after these patients, to support them both educationally but also emotionally, so that they're enabled to deliver that care for a daily review in the last days of life. The charitable pilot was successful in that we were able to then submit a second business case for substantive funding. It looks very simple when I put it on the slide here, but believe me, that was a lot of hard work, a lot of relationship building, a lot of presenting at various different committees within the trust, a lot of, as we were alluding to earlier, working with colleagues, talking to finance, making sure our modelling was realistic. But I'm really happy to say that by 2024, and we can continually monitor this data and have been able to sustain this level of improvement. Almost 90% of all deaths in the trust are seen by either our service or the specialist palliative care service, and about 2/3 of deaths within ITU are also seen. And we've managed to sustain that service going forward. Just to give you an idea of the scale, the business case was for 2.8 whole-time equivalent CNSs in a trust that has about 900 beds, and we have about 900 deaths per year. So that's the sort of scale. So it's significant, but it's not huge in order to be able to make that kind of impact. Next slide, please. So a little bit around that development of the clinical end-of-life service. We initially had implemented the SWAN model of care. We were ensuring that 7 days a week, so including the weekends, we were able to see patients in the last days of life daily. We developed a specific care plan on the EPIC system that we did a QI project specifically around that and presented that as a poster at the Palliative Care Congress. We also updated our EPIC template. So these patients, we review them daily, and we have a specific template that we developed for that review. And one of the key things that was highlighted for NACEL is that our initial records were not showing whether or not we were monitoring a patient's need to have for hydration and nutrition needs at that stage on a daily basis. So we updated our template, and we have improved that significantly, as you'll see on one of my further slides. We also piloted a VR intervention. We had a small charitable donation that we used to purchase VR headsets, and we initially piloted that on staff and presented that in post format, and are now using that with patients. Again, I'll go on to tell you a little bit more about that. Next slide, please. So in terms of just that feedback from that initial pilot, we made over 800 visits, and the vast majority of these address not just physical needs, but also emotional needs of patients and their families. We were also looking at where that was the patient's preference, supporting the patient to be discharged as quickly as possible, sometimes the same day or the next day, to die at home if that was their preferred place of care. And we assessed feedback and had overwhelmingly positive feedback. Next slide, sorry. So in terms of the sustainability, we have worked tirelessly to continually reassess not just patients, but their loved ones and the staff needs. Our initial small team had an educational only model, but we realised that with the high levels of staff turnover, it wasn't sustainable for that to be able to deliver the improvement of care that we needed, and therefore expanded to this clinical model. And in terms of innovation, as I've described, not just our use of the the electronic patient record to secure data, but also for us to have the tools in terms of templates for daily reviews for care planning, and then also our use of VR. And we did have a young patient very recently who had it on her bucket list to go on a safari. She was not well enough to get on an aeroplane, so we have 2 VR headsets, so we took them both so that she and her fiance could both have the same safari experience in VR. And actually that was one of the most positive elements of her last few days of her life here. Next slide, please. So as I said, with our updating of the EPIC template for last days of life, we increased our recording of assessment of hydration and nutrition needs at that time to 80% from just 50%. We're now focusing very much on cultural competence. We've rolled out e-learning to the teams across that, and also starting with the basics, just making sure that we are actually on our electronic system documenting religion and ethnicity and auditing our levels of that, and working across the trust with the key people to make sure that that's not just a local change, but that's wider within the trust too. We're continuing to focus on bereavement care, and this year we were very happy to be awarded a commendation from NASAL, and it was actually NASAL that suggested that we should submit for this award. Next slide. So this is just us celebrating 10 years of hard work with a picnic in Regent's Park. It is not, I see as I was awarded the this award that it was against my name. It really shouldn't be. It should be the whole Transforming End of Life Care team here. I don't think Jo Bennett's is on the call, but she's our lead CNS who works full time to my just 1 day a week. And it's really a tribute to our CNSs, to our project manager, and to Jo and to our fellow that we've able to achieve all of this and work hard to continue, because there's always the next challenge. Thank you.
Oh, thanks, Emily. It was both moving and just, yeah, awe-inspiring, wasn't it? The amount that you've managed to do. Okay, we'll go to questions then, if that's okay. I can see, Bren, you're back and you've got your hand up. Hopefully you can come off mute.
I can. Can you hear me okay?
Yes, I can, yeah.
Thank you. So I fiddled around with this IT and it's worked. So Emily, first thing to say is I was part of the judging panel for this, and I'm reading through it. It literally did more than touch my heart, really. And you know, the judging was tight and it was never easy, and rightly so, really. But for this, what I saw was actually progression and progression and progression with a purpose. I think that's really important for me, is that we really have clarity of purpose as well. So and very humble, Emily, to say it's the whole team, and I'm sure it will be, but there's leadership within that as well, really. So maybe take a brief moment around that, really, on even if you want to call it shared leadership, really. So thank you, really. And as you so a thought would be is, as you develop more around the cultural competency and the impacts, really, is I'd just offer a thought to touch in, and I declare an interest here because I'm part of it, the Race and Health Observatory, as they go forward some of their work. And I think there's huge opportunity for clinical audit to appear on what is going to be announced at the NHS Expo on their new portal, to develop a place of contact, really. And also, Sam, honestly, I've never sat through a presentation like that you've delivered. I know it's a separate one, but the only thing I would say on that one, Sam, is whilst we had the patient at the start, what I always ask both locally and nationally, as at what stage would you say no to having a patient there? So I think that's just a food for thought for later, Sam, for yourself. And I'll certainly go on your course, really. Emily, back to you. Congratulations.
Thanks, Brian. A couple of questions in the Q&A then, Emily. Hi, Emily. Congratulations on your award. How did you assess the quality effectiveness of your teaching programme?
That is a really good question, and in fact that's something I'm going to be doing this afternoon for the new for the new TEP Talks course, is thinking about the evaluation. Evaluation of education is really hard, and obviously the highest level is to be able to demonstrate change in practice. So I think the year-on-year improvement in our NACEL results probably, I get it, it's just a proxy because it's a notes audit, but it probably demonstrates some change in practice. In terms of our overall monitoring of the quality of care, we look at all different things. It's a dashboard. We look at complaints and incidents around end of life care. We look at the various different audits that I've outlined. We look at direct feedback from relatives that have of patients who have died in the trust. We do qualitative, small-scale qualitative feedback opportunities with patients on the ward receiving our care. But from the education specifically, what we're going to, with the Talking DNA CPR course and with the Compassionate Conversations courses, we just evaluate it in a fairly standard day on the way, in a fairly standard way on the day, looking at the learners' reactions, responsives, feedback for improvement of the course. With our new TEP Talks course, we're hoping to in some way evidence a change in practice, and that will be looking at getting feedback pre-course, post-course, and then perhaps 3 months after to see if there's been a change in practice. My ambition is to actually offer a little bit of in situ, to offer attendees a bit of in situ learning as a follow-up to the course, and actually offer to see if they would want assistance in a conversation that's happening in real time. But I'm not sure with the size of our team and the number of people who'd be confident to do that, whether it's something that's realistic. But yeah, it's something we're really thinking about. Thank you.
That's brilliant, thank you. And then how do you encourage completion of your NACEL carers survey?
Oh, that's really hard. That's really hard. So we've actually kept so on all our patient leaflets, the one that is about that we've developed for patient care in the last days of life, and also after death care, we have a QR code where it's an opt-in for relatives to give feedback, and we get low numbers, but we get some from that. From the NACEL, it's sort of out of our hands in that the letters go out, and so I don't think we get particularly higher rates than anybody else, and I think that's a national concern. I think everybody is over inundated with emails. Everybody's over inundated with opportunities to feedback. You only need to go shopping and then you get opportunity to feedback. So I think it's something we need to think about really carefully, is how we get the quality of carers feedback. We do at our board have 2 patient reps who we try and get the patient and who've both had experiences of end of life care within the trust of a relative. So we try and get the patient voice that way as well. It's an ongoing challenge that we need to think about really carefully.
Yeah, it's a challenge for all of us, that one, isn't it? So yeah, it's worth raising the question. Thank you. Okay, I think one last question, maybe in the interest of time. I'm seeing a hand up. I don't think it's an error in terms of clicking reactions. Joanne, are you able to unmute?
Hi, it's Jo Bennett. Emily, you've done brilliantly at presenting the work. I was just going to add in that our project manager, so I'm with the team at UCLH. So in terms of bereaved carers feedback, our project manager was sending out bereavement cards with the NACEL bereaved carers survey feedback would also be sent out separately. But NACEL did contact us to say we had a higher number of feedback, and we felt that it was probably down to sending the bereavement cards with that. So we do think there was some increased feedback through that process. That was the only thing that we could work out, that perhaps that contributed to them. But we know that from feedback, you either get the majority of really positive and then the really negative, and there's less of the in-between feedback. So yeah, but we have got some amazingly positive feedback. Yeah.
Thank you. Thanks, Joanne. That was lovely that you managed to add to that question. Thank you. Okay, thanks, Emily. Brilliant. Thanks for sharing, and thanks everybody for your questions. So, Louise, I think we'll move on to the next slide, if that's okay. Lovely. So if we just move on to the next one, then we've just got a QR code for you to scan, just so that you can pop some feedback in for us, really, and what we really want to hear is key takeaways. And obviously we'll share those again with everybody on the future NHS workspace, and obviously on the HQIP web pages as well for you. So we'll just give you a chance to scan that QR code. And then, as always, we said we would challenge you. And I think this year it's all around that value and that impact. So I think it's thinking about your national clinical audits and your local clinical audits as those are commencing. It's really starting to now almost question our teams more around how will this particular project add that value, and how is it going to impact on influencing that change to improve those health outcomes. So I think Louise is going to share the screen if we've had a chance to scan the QR code, and we might start to see some of your takeaways coming up on the screen. How to implement changes in clinical audit as a key tool. That's that evidence-based quality improvement process, clinical audit. Very robust. Yep. Lovely. Keep posting. We'll start to see them come up. So yeah, just having a think about then what you're going to take away, what are you going to do from today's information, how will that add value, how will that add impact, and how will you then measure what you've taken away and implemented? What metrics might you look at then to show that actually that's starting to make a difference to improving those health outcomes for all? And just touching on some of the key points that Sam shared with us, really, and how she's challenged us to think about the patient pathway and the system, and that collaboration with your partners in your system. So yeah, benefits of co-working here. Look, being data-driven benefits of co-working. We're almost talking to the converted here on our call today, aren't we? But it is really good to see good live examples that we can take away and take the shared learning from, be it with end-of-life care such as your team, Emily, or whether it's for any other topics as well. Brilliant. This evaluation is going to stay open. Louise won't close it for a week or two, so we'll just make sure that you're aware of that as we publish the recordings of slide packs. So if you want to add more feedback as you go, you can, or for any colleagues that you know perhaps had to leave the call earlier, there's the opportunity there for them to evaluate. And then, of course, for people that might just be accessing the recording and the slide pack as well. We do use the feedback for future events, and obviously to help shape what we can do to further support you back in your organisations. Thank you. So I think we'll move on to the next couple of slides then, just to share tomorrow's events as well, Louise, because we've got a couple of minutes before we close and we go off to make good use of our afternoon. So we'll get the slide pack back up and we'll just move on. Lovely. So this is what we've just challenged you with. Sorry, just going back one. Sorry, Louise. This is what we've just challenged you with around thinking about that value and that impact, and then starting to think about how we can work together across the system to really make that difference to our patient pathways, based on what we're now being challenged from Lord Darcy's review of the NHS and this awaited 10-year health plan that we're expecting in a few weeks' time. Lovely. So if we just move on, then we've got the QR code for tomorrow's Lunch and Learns, which is around efficiencies, and we're going to hear about a piece of work from the Royal College of Physicians from Dr. Teresa Barnes. So you can scan the QR code here and you can head over to HQIP's web pages or the NQICAN Future NHS workspace to register if you're not yet registered. So 12:30 till 1:45 tomorrow. And if we move on, I think we've got one other event tomorrow to tell you about as well. So yeah, so this is the HQIP Clinical Audit Heroes Award Commendations webinar, which is being held between 10 a.m. and 11 a.m. So you can head on over to the HQIP web pages to register if you're not yet registered for that event, but that's happening in the morning. And then the efficiencies lunch and learn, as was said, at 12:30 till 1:45 back here with NQICAN and HQIP again. And we've kindly got the QR code here to HQIP's web pages for all the resources, and the case studies are being published from the runners-up and the winners from this year, and more information around the award submissions as well, so do make use of that. So if we move to the next slide then. Yeah, I think that's it for today, isn't it? So thank you to everybody that's joined us. Thank you to all the key speakers, the winners, the runners-up, everybody that's submitted to Clinical Audit Hero Awards for any category, but obviously for influencing change. And thank you to you all for attending as well and participating. Thank you to Sam, our key speaker. Please head on over to the future workspace, the Making Data Count. We've popped the links in the Q&A for you, but obviously we'll make sure that we advertise that with the training dates when we publish the recording as slide pack for you. Yeah, I think that's it. I'm just double checking the Q&A. There's a couple more posts in there for you as well with some links. Brilliant, so just follow those as well. And thanks, Claire, obviously for giving us that HQIP update as well. Have a fantastic afternoon, and we'll see you all at tomorrow's events. Thank you very much.